asked to talk a bit about.
Sorry.
I've been asked to talk a little bit about peripheral nerve injuries, and I'm very aware brachial plexus and nerve injury is something that quite a lot of people get worried about. So I teach everything hopefully at a very basic level, and that's sort of shown. A lot of my practice is paediatrics, so I've got some cartoons, and this is in no way special teaching for you guys. This is the kind of teaching I give to all my colleagues, and so I hope you enjoy the cartoons and see the sense in keeping it simple. So we're going to talk a bit about nerve injury today. I work here in London, University College London, and the Royal National Orthopaedic Hospital and the Cleveland Clinic London. If any of you are interested in jobs in the future, we've just opened this wonderful, beautiful new hospital last week with a outpatient here in London. The building just to the right-hand side that you can't see here is the BBC Broadcasting House in central London. So keep an eye out for any jobs if you fancy coming over to London in the future. As I say, this subject does make everyone nervous. I have a Twitter feed. I don't know if you guys use Twitter, but certainly if you want to interact, I put a lot of educational stuff up there. And we don't have much time today to cover an awful lot, but there's a lot online. So I've got some good friends in OrthoHub, which, if you don't know about it, is a great orthopedic resource, musculoskeletal resource, orthohub.xyz, or Z, as some of you might say. If you click on that QR code, it'll take you to a whole pile of video nerve examinations. So check that out. My website is at the bottom there as well. So if there's any questions or anything you want more of from this, please use those resources. So we're going to talk a bit about nerve injury, but also brachial plexus injury. And a lot of these cartoons are done by my friend Artibiotics, and there'll be some links to him as well later on. But what we're going to talk about is nerve injury. And with any injury, any trauma, it's really important to recognize the mechanism of injury. So was this a trip and a fall while walking, or being hit by a train, or stabbed with a machete? All of these things mean that there's going to be a different type of nerve injury. So with any injury, whether it's to the spleen, whether it's to the bones, whether it's to the brain, mechanism of injury is really key. Clinical examinations is one area of medicine where there aren't tests and imaging that you can do to give you an answer. So it's old school medicine. It's taking a history and doing an examination. And then we'll get to a diagnosis. Now, as I'll explain, nerve injury isn't a diagnosis, just like sore knee isn't a diagnosis. We have to go a bit further than that. And then we'll get a bit of the treatment options that we can offer. And everybody throughout history has always thought you can't make nerves better, but far, far from it. I'll show you some results. So why listen to me about this? Well, it's all I do. Many people specialize in nerve injury within plastics and do hand or breast, or within orthopedics, or within neurosurgery. But my whole practice is dealing with the nerves outside of the spinal cord and brain. And I do that clinically in adults and kids. I have an international practice, a national NHS practice here in the UK, and also it's my research area of interest as well. There are some gruesome pictures. I should have warned you a bit about this before, but on the top right there's a picture of a 3-month-old baby's brachial plexus with a collarbone that's been cut in that top left, and the other half of that's in the bottom left, just underneath the piece of material we've used to put the sural nerve grafts in there. And that white bubbly stuff is collagen, tissual glue, which is used to secure those. And on the bottom right, there's a picture of an armpit, an arm, and the chest. And I've taken intercostal nerves from beneath each of those ribs, the motor nerve to the intercostal muscles, and I've used those to wire into the triceps muscle in the arm. So an introductory to nerve injury. Nerve is an amazing structure. It's highly functional, functionally concentrated. So if you take away a chunk of bone, or you take away a chunk of muscle or a bit of liver, you're not going to notice much of a problem. But you take away even a tiny bit of nerve and you're likely to see a problem. Now, nerve, the English word nerve we use the same for the cell, the nerve cell, as well as we do the whole macroscopic thing. If you all feel on the inside side of your elbow here, you'll feel the ulnar nerve. You can see mine just snapping there over my medial epicondyle. They're about the size of your finger, little finger, most of the nerves. The radial nerve you can feel wrapping around here. As I say, the ulnar nerve behind your elbow. The median nerve also at the front of the elbow here. They're about the size of your little finger. And the cells within that we also call nerves, but we'll try and call those neurons just to make that separate. So within a nerve, there's neurons. There's also an awful lot of other packing around them. So collagen, elastin, blood cells, and arterioles and venous supply to bring in the oxygen and energy and take away the waste products. And nerves do an awful lot of things. People always tell me if there's a nerve injury about the motor loss, so they'll tell me there's a wrist drop from a radial nerve injury, but they'll often forget to tell me about the touch, the temperature, the control of muscle, sympathetic function, and neuropathic pain. And we'll touch on all of those as we go through today. So here is one of the neurons, the nerve cells. Obviously it's a bit magnified, but nerve cells are huge. Everyone thinks that cells are teeny tiny things, but nerve cells can be up to 2 meters, 1.5 meters in length, which is surprising for one cell. But most of that is the axon, this long, thin process. That cell body, the bit there with the nucleus, is where all the proteins are made, and they're pumped down the nerve, and the nerve is there to pass electrical information. It's highly specialized to pass electrical information, binary information of an action potential, backwards and forwards, up and down it. Some have myelin around them, and this is a fatty insulation, and it allows the electrical signal to jump rather than have to run. It jumps and steps along, and that makes it faster. But all nerve cells, neurons, are linked with a Schwann cell. The Schwann cells in this neuron are myelinating, but the Schwann cell is the glial cell or supportive cell of the PNS, the peripheral nervous system. In the CNS, in the brain and the spinal cord, there are other glial cells, oligodendrocytes and astrocytes, and they do very different jobs when axons are injured or neurons are injured. The Schwann cell, as I'll show you, is the key cell that allows us to regrow axons. And here's a beautiful dissection. The middle bit's the stuff I don't do. It's locked up in a bony box of the skull and the spinal cord. But everything outside of that, outside the dural sac, is PNS, and that's all Schwann cell and can all get better. But as you know, if you damage the brain or the spinal cord, the chances of regrowing those things are really small. We rely on the brain learning new ways to use what it's got rather than regrowing stuff. So nerves run from the brain and the spinal cord to control the whole body. And nerve injury, therefore, can affect any part of the body. And I do all parts of the body, so it's great. I get to go in the neck and the chest and the abdomen, the pelvis, the leg, the feet, the toes, everything. But the key thing is when we lose all those functions of movement and sensation and we get pain, patients can end up with painful limbs, stiff, paralyzed, dry skin, and stiff joints. So this is the key thing that we need to try and combat when we see nerve injury. So trying to remember to get people to assess motor, touch, sympathetics, and pain, all those modalities of nerve, we need to remember this, and I use the term might try something professional. So motor, touch, sympathetics, and pain. So whenever you see a nerve injury, think about the mechanism and then examine the nerve for all of those aspects. And we'll talk a bit about that. But as I say, I've got lots of videos online of how to examine nerves. This is more about nerve injury. But nerves don't like being stretched. They can be stretched very slowly, up to about 5, 6, 7% strain. So if you take a meter long nerve, you can take it to a meter point tiny bit. And that's if you stretch them slowly. If you stretch them quickly, they tend to snap. And they don't like being squashed. And they definitely don't like being cut. And we'll talk a bit about what happens when we cut nerves in just a minute. But the classifications that you've probably heard of and been taught in medical school and seen in books are the Sunderland and the Seddon classifications. Now, Sedden's an awful lot of Greek. It's hard to spell, it's hard to pronounce, and people generally tend to do neuropraxia, which drives me crazy, because neuropraxia means nerve working. The word is actually apraxia, nerve not working. But I call that conduction block. We'll get to that in a minute. But these are a bit unhelpful because they talk about individual axons and they don't help with the overall, so individual neuron injuries, where we want to know about the whole nerve. So I introduce you to my little worm. So if you cut a worm in two, what happens? What we don't get is two worms. We get the head bit that lives and the tail bit that dies. The head bit lives because it's the bit that can create protein, can eat. So in our neurone, that's the cell body side. So if we chop a worm in two here with my Tom Quick branded cap on, we chop a worm in two, the distal bit dies and a new tail grows. And this was described by a guy called Waller. So we call it Wallerian, to do with Waller, degeneration, the fact that the distal part of the axon dies away. And these Schwann cells are key. So here's our nerve, our axon, and we're going to cut it in two. What happens, the Schwann cell demyelinates, so it eats its own myelin to get some energy, and then it starts to support the growth of the axon and then remyelinates again. So once again, that worm dies, it tries to regrow, it's supported by the Schwann cell, and then when it's regrown, the Schwann cell can do its normal thing of, if it is a myelinating Schwann cell, go and do that. So the Schwann cells are the key. So here we go, we've got the cut nerve on the top left. It dies away, Wallerian degeneration, remember the worm. Those Schwann cells help it, and in the end, it reconnects. And this is a wonderful picture drawn by a man called Ramon y Cajal. And he traced these from micrographs, from pictures down a microscope. He cut a nerve and he pulled it ever so slightly apart. And the top bit is the head end, and the bottom bit is the tail end, so the nerves are trying to grow down the picture. And each of those teeny tiny blob ends that look tiny, a bit like a sperm, they're the growth cones. They're the end of the worm trying to grow. So all of them have started here at D and they're trying to grow down, and some have reached to F. Some have got stuck at C, and some have decided to go totally crazy and go the wrong way at A. And this is all because of this gap. So what we try and do is avoid gaps, because down here in B, all these Schwann cells are trying to feed the nerve and get it to grow down. But what we don't like in nerve injury is gaps, because it allows the axons to escape. And here's one of those endings, the growth cones. It's like an amoeba. It can smell and sense where it needs to go. So this is degenerative nerve injury. And we can split that into two types: favorable prognosis or unfavorable prognosis. So if I squash my nerve really tight and then let go, enough to kill the nerves, all of their tubes and all their Schwann cells will be there. And this is bottom of this picture. All of them will then be allowed to grow down. But if I cut a nerve and leave a big gap, all of the axons, all of those growth cones will stay still, and they'll all be left here. Now, how do we know where the growth cone is? We've got this wonderful test called a Tinel test, named after a man called Mr. Tinel. And what that means is if you tap on the growth cone or tap on the cut end of the worm, the head goes, ah! So if I cut my radial nerve here and tap on it, that creates a signal. All of this nerve here has died, but I tap here on the growth cone and the signal goes back to my brain and it tells me that there's tingling here. Whereas actually, if I was to touch here, I wouldn't feel it because the nerve has died away. But my brain interprets the tapping here and the signal going back in the nerve as ants crawling all over here. And in this example, if I'd started the cut and the crush off at the same time, they both have a Tinel at this point. But this picture is months down the line, and the crush Tinel has grown further and further and further. So this Tinel is now way off the left-hand side of the screen. Whereas the Tinel here, because it hasn't got those lines along which to grow, has stayed still. So the cut has a stationary Tinel, and this is a neuroma, and I'll show you a picture of a neuroma in just a minute. But the crush has allowed those growth cones to grow. There is no neuroma. The Tinel would advance, and like our diagrams, we've seen how that advances. So if we can get a nerve together, stitch it together without a gap, all of our axons should grow down. Some teeny tiny ones might escape. If we have no gap, we're trying to get none of them to escape. If we've got a big gap and I can't bring those together without tension, and this is true of any kind of tissue, if you've got skin and you're pulling it together to make it stick together, it becomes necrotic and won't heal. So if you're really having to pull things to get together, it's never good. But if I can get the nerve ends just to sit nicely together, then we can do the primary repair, like I've just done, stitch it together. But if I can't get them together, I have to put some gap material in, and we use nerve graft for that. And I'll talk a bit about that. But that, again, is a way to allow the nerves to grow down, but we've then got 2 repair sites where those axons can escape. The other type of injury, other than degenerative nerve injury, is this thing called neuroapraxia, which is Greek. So let's use an English word, conduction block. That is where it's anatomically intact. It hasn't died. It hasn't degenerated. There is no worm. There is no Tinel sign. It's anatomically intact, but physiologically broken. And for this, I'd like you to think about a bomb and a fuse. I don't know if any of you are old enough to have seen the Wile E. Coyote and Roadrunner cartoons, but they always used to give each other a bomb with a long fuse, and they'd hold it while the fuse would go, boom, would go off. You think about the fuse as the nerve and the bomb as the muscle. If that fuse gets wet, the fire goes out. It's still, the fuse is still there. It's still available, anatomically intact, but it's physiologically broken. It can't transmit that impulse. So if we have a, oh, sorry, I've got these the wrong way around. So if we've got this conduction block, the signal can't get by. Okay, the fire goes out. That's a squash injury. Generally, it can be a mild stretch injury, but it means that you've got an area where there's no resting action, no resting electrical potential to allow an action potential to go by. And this is generally compression or anoxia, hypoxia, which means the sodium potassium ATPase can't work, which means the resting potential drops away. Sometimes it's so bad that the scarring there is permanent, and I've got to go in and take that away. But most of the time, it resolves by itself. So a Saturday night palsy, if you've got your arm over the back of a chair and you fall asleep, you might get a radial nerve palsy through a conduction block. The mechanism is mild, and it will come back by itself over weeks or months. So that is conduction block. Okay, so remember, mechanism, might try something professional, and then our classification, which is degenerative, favorable, non-favorable, or conduction block. And conduction block can be spontaneously resolving or require intervention. So when we come to assess nerves, motor is the major thing. It's what everybody notices. It's what people tell me about all the time. There's a wrist drop. I can't make a fist. And the way that we assess motor function traditionally is the Medical Research Council muscle grading system. And that's an old thing from after the war that was agreed, and it's from 0, no function, to 5, that's normal. And it's pretty useless for 1,000 reasons, but it's what you guys will get asked about in your exams. This whole slide was my thesis in my doctorate, and it's all about what people notice when they've had muscle that's been de-innervated and re-innervated. Me and a number of my colleagues have looked into this to see what the subjective experience of motor recovery is, and people don't really care what that peak force is because they hardly ever use it. Most of you will never access the peak force of your muscles, so why measure that as an outcome? Most of it is how you control the greater ability of force, how easy it is, and the whether it feels natural to you. But anyway, that's my hobby horse. Sensation, you will know these maps. I'm sure you've seen these are root level problems. So if I damage things right at the root level, I lose a strip of tissue. But if you damage nerves, they come out in a different pattern. And it's about recognizing which of these patterns are involved to work out where that injury is. And all of neurology is this question: where is the lesion? Where is the problem? And we can look at which muscles are working and which bits of skin have normal sensation, whether they have neuropathic pain, whether they have sympathetic function, and put all that together with some experience and practice into working out where the nerve has been injured. But the difference between that and that is essentially how we do sensation, sympathetics, neuropathic pain. And what do I mean by sympathetics? Well, the tiny nerves that control the way your heart rate works and your bowels work also controls your skin. And the rugosity of your skin and your fingerprints and sweating and the thickness of skin are all controlled by nerves. So we assess all of those things. And then neuropathic pain, we've done motor, touch, and sympathetics, and now pain. Neuropathic pain is different to nociceptive pain. These two types of pain. Nociceptive pain is when your nerves detect tissue injury. So a blowtorch on your hand or infection in your finger. Neuropathic pain is when the nerves that detect pain go wrong, a bit like the smoke alarm going off when there's no fire. And it's really difficult. It's severe pain, and it can create a huge amount of problem. There's a number of surgical causes that happen after trauma that create pain. And here is one of those neuromas that I mentioned earlier. This is a nerve that's been cut in two, and the distal bit's gone, and those nerves, the growth cones, are nowhere to go. They form this painful blob. Every nerve that's cut will do that. Some don't become symptomatic, but this one did. It became a symptomatic post-traumatic neuroma, painful lump. And so we did something clever, and we chopped it out and we wired the nerves into a muscle so they weren't going to form another lump. But there's a number of other aspects of nerve injury. One specifically I'm going to touch on in just a minute called neurosternalgia, which is another form as well. But nerve injury is complicated. And what's really useful, and if you don't know about this, then I would learn about it. This is called the ICF, the WHO International Classification of Function. But it essentially says that in any problem, any health condition, there can be a problem with the body function and structures. You could have a neck of femur fracture, or a gallbladder cancer, or a nerve injury. And that will interact with what you can do, the activity, and thus how you work in the world, which is participation, socially, employment, relationships. And that will interact with your health condition and the environmental factors. So it'd be easier perhaps in the summer than it is in the winter. It'd be easier if you are middle class than if you're working class. And personal factors, your background state. So all of those things come in together, and even more so in something complex like a brachial plexus injury. So some summaries before I just go on to the brachial plexus. So if there's any questions, fire in now. Nerve injury is something that can cause chronic problems, can cause problem from when it's caused for years and years afterwards. And it's not many things. A broken bone, a sprain generally get better. Nerve injuries left can go on and cause problems for ages. Outcomes are often poor because of the way they're managed. And it involves the input of an awful lot of colleagues working together to the best outcome. Surgery should never be undertaken by a surgeon in isolation. A surgery is never going to make someone better. It will help the rehab, and therefore the rehab is the thing. All of that, you need psychology, you need physical therapy, occupational therapy, prosthetists, pain specialists, play therapists if it's kids. And because it's complex, it's not something to mess about with and try whenever. So it's something that's good to do a lot of and try and concentrate that work. Any questions on nerves, nerve injuries, or anything else? I'm just going to go on some brachial plexus stuff in 10 seconds if everyone's happy. Looks like I've stunned you all into silence.
Quick question, actually.
Yeah.
Let's say, for example, okay, this is going to be a little bit extreme, but let's say when it comes to like an amputation, for example, and you would have to deal with the nervous complications of that. So in that case, obviously the cut would be like, deliberate. So how would you exactly like make sure that the axons don't continue to, the growth cones don't continue to grow?
Great question. So if I go back to our neuroma, so every nerve that's cut, and in the leg, say, that will be the tibial nerve, the common peroneal nerve, the saphenous nerve, the sural nerve, all of those will create a neuroma. What you want is it not to create a symptomatic neuroma. Most people with an amputation will have amputation stump neuroma. We prefer the term residuum rather than stump. Stump sounds a bit awful, but it's sort of stump neuroma is a thing. So if you touch and prod around inside someone's residuum, the bit they've got left, they will feel symptoms in their phantom. So if I prod the back of their stump, they'll feel tingles on the bottom of their foot or the top of their foot, because I'm stimulating this neuroma. If that's not causing pain, there's no reason to do anything about it. That's the natural thing that nerves do. As I mentioned, and when I get to treatments in just a minute, we'll cover one way that we can stop these happening, but it's been the attention of surgeons for generations, hundreds, in fact, thousands of years. People have been knowing about this and trying to stop them. We can't easily stop them, and that's the problem. But one thing we do know is they can't be anywhere tethered or anywhere near the skin. Skin pumps out a holiday chemicals to make nerves grow, called nerve growth factors. And if you expose a neuroma to skin, it gets really sore. And if it's tethered and gets pulled, mechanically stimulated, will also cause pain. And so what you want is that nerve to be buried deep next to muscle, well, way away from skin and not in skull. Does that answer your question?
Yes, it does. Thank you.
Cool. Okay. So, summary, mechanism, I might try something professional, motor using the MRC grade. We're going to assess touch out of 10, but remember, we're going to ask people how it's feeling. Is it weird? Does it feel strange? We're looking at sympathetics. We're thinking about neuropathic pain. We're testing for the Tinel sign. And then there's something which we can do another talk on another day, but there's nerve testing and imaging, but they don't really help unless you've got much of a clue from the others. Okay, so I said nerve injury was not a diagnosis. People seem to think it is. This patient has got a nerve injury. You would never say this patient's got a sore toe. You'd say they've got a fracture, they've got an infection, they've got a tumor. You try and get to a diagnosis. And in my job, it's strange. Nerve injury seems to be something where everyone just gives up trying to get a diagnosis, and they just say, there's a nerve injury. And I get referrals like this all the time. We think there might be a nerve injury. No one's actually, that means no one's looked. That means the patient's complained of something and no one really knows. Or my boss thinks there might be a nerve injury, which is the boss hasn't examined the patient and I haven't examined the patient either. Or the patient thinks there might be a nerve injury. And then they almost always say, it's almost certainly nothing wrong, but could you see anyway? Because they're obviously worried. And so to try and avoid that, we've got some standards here in the UK, and these are really useful documents for you to see. This actually I should have updated. We've just rewritten the BOAST guidelines. If you're interested in orthopaedics or neurotrauma or plastics, the British Orthopaedic Association Standards for Trauma, which we call BOAST, B-O-A-S-T, published online and free access, and they're between the plastics and the ortho and the hand surgeons here in the UK. And they're really useful documents as guidelines of what to do. And this is a really old document, over 11 years old now. And that again is a document on how to deal with nerve injury. So have a look at those, they're useful. And as I say, I was on the board and we've just done an update for BOAST for nerve injury. So this picture there, brachial plexus, what is it? The brachial plexus is a switching board. It's just where nerves come together. Plexus means net or interconnectedness. And there's one for the leg and there's one for the arm. The arm's the brachium, so we call it the brachial to do with the arm plexus network of nerves. And it sits here. And I'll show you some pictures. In fact, if you all tilt your head to one side, you can feel it just here. So here's my collarbone. I'm going to come up, and if you just pull, you'll feel it tighten just there. It's kind of uncomfortable. I'll show you exactly where it sits. Okay, so we're going to go through this. This is a beautiful wiring diagram. I'm going to steer a bit clear of this, but it's available all over the internet. And I think it's one of the best because it uses those colors to show you where all the nerves go. But anyway, this is the picture from my friend Antibiotics. I've just flipped it the other way around because it then correlates with this picture, which is a picture from a 1950s textbook, which I think is quite beautiful. So the collarbone, the middle bit's been taken out. We're looking at a picture just like me here, and the nerves that come out of C5, so the 5th cervical level, 6, 7, 8. There is no 8th cervical vertebral body. There's only 7, so the 8th comes out in that gap between, and then the T1, the first thoracic. All these nerves come together and they mix up and they come under your collarbone, down in front of your shoulder, and then start to split. You've got the axillary nerve and the radial nerve and the median, the ulnar, and the musculocutaneous. And you've heard of all these nerves. They all come from this part of neural anatomy. So that's where it lies. And this is how it generally tends to get injured. Injuries where your head is stretched. And this is the supraclavicular, the bits above the clavicle get stretched. You can feel it. You put your finger and stretch your head, you'll feel it tighten. You can imagine that distance is getting longer. And this is classically high energy injuries because there's a load of muscles and ligaments around here. This is quite more vulnerable because if you're going to get injured, things tend to hit you here. As we get injured, we sort of protect our necks like this. And so the necks tend to not get as injured with low energy, whereas here, shoulder dislocations, as you can imagine here, there's the shoulder joint, you can see that here. If that dislocates, that can damage things, and that's relatively low energy often. But high energy injuries for here, so it's road traffic accidents, stabbings, coming off horses or falling from heights. And there you go, that's a standard injury. That's a whole load of injury with someone unprotected, helmet on to protect the skull, which is even more weight, and an injury to the brachial plexus. And this is common. 2/3 of injuries are motor vehicles, 2/3 of those are bikes, and 2/3 of those are men. So it's a pretty standard injury for us. There is also, this is a beautiful picture from Hunter's huge book, which is in the British Library. The book's about 5 foot high, these beautiful illustrations. This can happen with something called Erb's palsy. So in a similar manner to that bike injury, you can imagine this child's top shoulder could get caught, the head's delivered, and then there's traction that same way placed here. And that was what I showed you earlier with those nerve grafts. In high energy injuries, which can be in birth injuries, but generally in motor cycles, the nerves can be pulled clear from the neck. And here we can see a pseudo meningocele where the CSF's been pulled out into the neck. Normal here on this side where the arrow is, the nerve's been pulled from the spine, which is in the middle here, and pulled all the way out. And I've got a video, so here's a diagram, and here's all the rootlets, and this is normally where the nerves would leave into the neck. All of these get pulled out. We can see this thing here called the dorsal root ganglion. This is information going into the spine, and information comes out through these ventral roots, forms a spinal nerve, and then comes out through the spine. If all these are pulled out of the spine, you get an avulsion. And here, so this is a swab on someone's neck with a cut that I've done here and a swab placed just here. You can see a dorsal root ganglion and the rootlets. So these were in the spine. It's been pulled clean out. So the worm that's trying to regrow is deep within the spine. There's no way I'm going to get that to grow back out again now. So that's the worst injury, an avulsion injury. And here is that same patient, and I'm going to now electrically stimulate. This is only, well, number of hours, I think about 16 hours after the injury. So if I stimulate, those nerves have not yet died away. So the worm has not yet died away. So if I stimulate,
so we've got C5 spinal.
If I stimulate the C5 root, I can stimulate the dorsal root, nothing happens because that's the information back in, that's where the sensory fibers go. If I stimulate the ventral root, it still works because we still haven't had time for that nerve, to that worm tail to die away. So there, ventral root causes stimulation and a dorsal root doesn't. The dorsal root's all the sensory nerves. Now, if I did that a day later, none of that would work because all the worm tail would have died away. But I'm stimulating the tail and it hasn't yet died away, and so it still works. So it can happen by surgeons damaging nerves. As we said, it can happen in childbirth. Stabbing's incredibly common. I'll show you a picture. I'm sorry, another gory picture coming up. And the awful children torturing bouncy castles and trampolines. Kids get injured so much from these and often fracture bones and cut nerves. Here is an arm that was attacked with a knife. Quite a lot of this I've done to open up, but in the middle here was a huge stabbing from a machete, and it cut the artery, which we've repaired, and all the nerves, which are the two ends here. You see the rather large nerve gaps that we've got. So we've got to take loads of nerve graft to get these proximal bits to grow down into these distal bits. So just a few minutes more. I'm going to skip through a bit of this. I'm just going to get to pain. Let me just mention this briefly. If a muscle is de-innervated, you have to get a nerve back to it quickly. At a year, even if I get a nerve to a muscle, it won't control it anymore. So this is the urgency in nerve injury. You can't just watch and wait. You need to know what's going on and do the best thing. Because if you get to 9 months, 10 months, we're thinking these nerves grow 1 millimeter a day. So if we don't get a nerve down to a muscle, by a year, it will never work. So an injury here will never re-innervate the muscles within the hand. So it's really important to get the proper diagnosis. This is that neurostenalgia that I was telling you about. Here's a nerve that was damaged, and this is scar. And this scar creates conduction block, which hopefully will resolve when I freed it up like the puddle, but it's also squeezing that nerve and causing pain. So that's another one of those surgical causes of pain. And here is pre and post-op after we've taken away scar from nerve. It's much better. And on the right-hand side, not great data, but a study that we did showing that the longer you leave the taking away of the tight scar, the less good the getting rid of the painness is going to be. Here's nerve grafting. So a gap in a nerve, we can't get the edges together. So we'll take a nerve, often the cerebral nerve, which brings feeling to that small patch on the foot. We'll take that nerve as spare parts. We're taking the tail of the worm. So nerve graft has no nerve in it. It's just channels down which to grow. And we'll splice that in. And here's that nerve graft again from an obstetric case. So here's nerve graft from the cerebral nerve, growing the proximal bit down to the distal bit here. And then we've got something wonderful called nerve transfers. And this is where we take a nerve passing the injury. So I've got an injury here and it's referred late. I don't have time to go all the way down to the biceps, but there's all the nerves to the hand passing right by. So I can steal some of those and wire them in. So there's a long distance here that I can't do, but there's a working nerve. So I can cut the working nerve. I'll lose some function because of that, but I'm going to throw that up to grow into, thus short-circuiting that gap. And that's as if we have, that's as if we have a TV that's broken, but we've got the lamp nearby and I can steal the wires from the lamp to control the TV. And what happens with this, if I take the nerves that bend the wrist and grow them into the biceps, I'll still have the wrist bending, but I'll now also have biceps power when I bend my wrist. And in time, the brain, through cerebral plasticity, can learn to isolate elbow and wrist separately. But we've taken the nerves that were coming down past here to flex the wrist, cut them, left some that still do that, but wired these nerves into the biceps. And then when the brain says bend, both happens. And in time, you can learn that. And here's a lady whose C5 and C6 were pulled avulsed from her neck, so she wouldn't be able to use her shoulder or her elbow. C5 does shoulder function, C6 elbow function. So she wouldn't be able to bend her arm or lift her arm up. I did nerve transfers for her. And she's back climbing. So the right-hand side was the injured side. She's rock climbing with this arm. So she's got external rotation, she's got abduction, she's got elbow flexion. All of that through taking nerves passing by. I took the nerve to trapezius, to put it to the deltoid, to the rotator cuff, some from triceps to the deltoid, and some from the wrist to the elbow. And we mentioned about taking nerves and stopping nerve endings form. We can do something a bit like a nerve transfer. But if your arm is amputated, the arm is not nerve injured, but has to come off for another reason. I've got all those wires. So if I think, make a fist, the signal's going down the nerves, but goes nowhere. So what we can do is take those nerves and wire them into the pec muscles. And then we put a transducer on the chest and we tell the patient, imagine you're making a hand with your phantom hand, and those nerves will stimulate now the pec muscle. And you can see at the bottom right here, we can tell the patient to do things and teach the robot, that's what you're supposed to do when you see this. And then the patient can think, make a fist, and the robot will make a fist. And this is called targeted muscle reinnervation. But those nerves won't form neuroma now because they're going to grow in and control that muscle. And so this might be the future. As I say, with some injuries, they're so bad we can't grow the nerves far enough and we struggle with stiffness and with pain. It might be that in the future we're going to be able to control things a lot better. The problem is still getting information back. Feeling into these hands is really difficult. There we go. That is my talk. In summary, nerve trauma is complex. You need to think about the mechanism. Consider neuropathic pain. Again, it's the most horrible thing to have. It can be cured or at least reduced in most cases. Always try and get a diagnosis. Remember that time is muscle. We can't leave things and just watch and wait. And there is no expertise in isolation. That means we all have to work in teams. Follow me on Twitter or have a look at those nerve links for lots more. Any questions?
I did have one actually. So you mentioned that on the stabbing case, the machete one, you had to repair the artery first. Is it normal that peripheral nerve surgeons also have to repair arteries as well as nerves, or is it just another team?
So actually on that day, that wasn't me. I am capable of doing it, but I'm A, slower, and B, less good than someone who does just arteries. So I would invite an artery surgeon, a vascular surgeon, to come join us. And we do all of our surgery as a team again. So they would take a vein from the leg, reverse that around so it will flow and plumb that in, and that will take them 20 minutes, half an hour. I could do that in an hour. I'd be slightly, well, maybe a lot less good, but it makes sense to work in a team and take all of those skills. And again, if you have all of those skills, great, but you're probably not going to be as great in each of those individual things. So if you've got the ability to bring, if there's a broken bone, again, I'm trained as an orthopedic surgeon, but it's a long time since I've fixed bones. I'd still rather someone comes in, knows the kit, it's quick, it's easy, it's done, rather than me take 2, 3, 4 times longer. So again, it's about that teamwork. So on that occasion, we had a brilliant colleague come in, revascularize the limb. There's no point me getting muscles to try and contract if they don't have blood flow, because they contract and get stiff and won't move.
Thank you very much.
Right.
Does anyone else have any questions? Okay, well, if that is the end of the talk, just please let me share my screen. I just have a couple of housekeeping notices. So as you can probably see, I just have to inform you guys, we have a conference coming up on the 7th and 8th of May. And as you can see, right at the bottom of the slide, you can feel free to scan the QR code to find out some more. And before you go, we also have a feedback form for Mr. Quick. Also, if you fill in your feedback form, you also get a certificate of attendance and let us know how everything went. And other than that, and after I post everything on the chats, yeah, you all can leave. So have a nice evening.
Thank you, everyone. Have a great evening.
Thank you so much.
Give me a second to post the feedback, sorry.